Okay. Hello, everyone. And we are delighted to present you all for One and One for All public seminar series on mental health in academia and society. All for One and One for All talks will shine a light on and discuss mental health issues in academia across all levels, from students to faculty, as well as in wider society. Seminars are held online once per month on Wednesdays at 5 p.m. Central European Time or 11 a.m. Eastern Standard Time, and free for all to attend. Speakers include academics, organizations, and health professionals whose work focuses on mental health. Live Q&A sessions will be held after each talk. For live webinar schedule, please visit our webpage at Lashuel Lab/upcoming webinars, or also follow us on Twitter at Lashuel Lab. Our conversation today is between Dr. Julia Dratva and Dr. Hilal Lashuel, as well as me, Galina Limorenko.
Welcome, everyone, and thank you for joining us. The corona pandemic has impacted the lives of everyone in our society in both predictable and unpredictable ways. It will most likely take years and possibly even decades to realize the full impact of this pandemic on our physical and mental health and how we work, learn, and educate in the coming years. Even before the coronavirus outbreak, COVID-19, students, advocates, and organizations were raising concerns about and sounding alarms about the growing mental health problems and challenges in academia and universities in particular. Studies carried out in different countries across the globe showed that large percentage of the students, around the 30%, attending universities experienced anxiety, depression, and other serious mental challenges. In early 2002, university students across the globe were confronted with abrupt changes that impacted not only their learning experiences and social life, but also their mental health. In Switzerland, in March 13, 2020, the Swiss government canceled face-to-face educational activities, banned all events involving more than 100 people, decided to partially close its borders, and implemented some border controls. Such sudden changes, disruptions of daily routines, unexpected stressful changes, and the uncertainties they trigger that impact all aspects of one's life can undoubtedly lead to an increase in anxiety, depression, mental stress, and our ability to manage our own emotions. Today, there is consensus that students' mental health is an issue that can no longer be ignored, and one that not should receive more attention and become a strategic priority for all universities. Previous studies have demonstrated a direct correlation between physiological distress, poor academic performance, and career outcomes, in addition to reducing the quality of life. This further underscores the critical importance of why universities should consider the mental health of their students, faculty, and staff a strategic priority and begin to invest more time and resources to provide the appropriate support to those affected and to implement actions aimed at preventing or reducing the individual and contextual factors that contribute to triggering physiological distress or amplify mental health challenges. In today's webinar, we plan to put the spotlight on the mental health of students in Swiss universities. And there isn't a better or more qualified person to help us address this topic today than our guest, Professor Julia Dratva, who has conducted and published several studies over the past couple years on student mental health and experiences in Swiss universities during the various waves or phases of the COVID-19 pandemic. Professor Dratva is a specialist in prevention and public health and a professor of public health at the Zurich University of Applied Sciences. There, she heads the research area, Health Sciences, at the Department of Health. She's also an associate professor at the Medical Faculty of Basel and president of the Swiss Society of Public Health Physicians and vice president of PHA Child and Adolescent Public Health Section. In addition to her research, which focuses on children and adolescent public health, she has a profound expertise in health monitoring and observational cohort studies. What distinguishes Professor Dratva's work from others in the specific areas that she has conducted longitudinal studies, unlike the majority of published studies on mental health and COVID, which are primarily cross-sectional. Her work, as we will learn from her today, has helped identify positive and negative predictors of anxiety, depression, and mental health challenges, and is informing recommendation and practices to help improve resilience and social and educational support to help students, and to ensure that universities are ready to handle not only the long-term ramification of this pandemic, but also be prepared for future challenges and outbreaks. Thank you for joining us today, Professor Dratva. We're looking forward to your lecture and our discussion. So the format of today's webinar is slightly different. Professor Dratva will give a presentation summarizing her work in this area, and then we'll have a conversation followed by a Q&A session from all of you. So please feel free to post your questions, comments during the whole session in the chat window. Thank you again for joining us. And thank you again, Professor Dratva, for making the time to be with us today.
Thank you very much, Professor Lashuel. I'm very happy to be here today and to present our data to you. I'll quickly share my slides. Let me see. And then go into the presentation mode. Oops. I see. Did that work?
Yeah.
Now, I think that should be it, huh? Perfect. So I'm going to talk to you today about the health of Swiss university students during the COVID-19 pandemic. And these are our students. I'm from the ZHAW, so a University of Applied Sciences in Zurich, Switzerland. And we investigated our own student body. We're a group of professors on public health, but also psychology. And I'll quickly introduce the study, which we abbreviate as HES-C for health in students during the corona pandemic, to you, and then present some results on preventive and risky health behaviors, as well as mental health outcomes and symptoms. And then to put it all together, I have like 3 discussion points that we can maybe then use as a starter for discussions. Okay, so this is a graph that I would like to use to show you how our study looked like, both from the perspective of a study design, but also with respect to its longitudinal approach. So as you just heard, in Switzerland, the lockdown was started middle to end of March, 23rd of March, and we planned right away a study in our student body, and we started 2 weeks into the lockdown with the first baseline survey here indicated with this small triangle. And you see these boxes, they represent the semester. So this is spring semester, then we have autumn semester and another spring semester in 2021. So overall, we covered 3, I call them pandemic semesters, in which there was this disruption of the studies and mainly online teaching. And you can see these triangles down here. They show the number of surveys that we did. We did 3 surveys per semester. The first one was always a bit longer. And then we had 2 follow-up surveys throughout the semester. And so overall, we have 9 time points in these 1.5 years that we have data on our students. We had our main study questions were to understand if and how the pandemic impacts students' educational, but also their everyday lives. We want to measure their mental health and resilient and scoping skills, and address ongoing changes So when there were changes in the pandemic, due to the pandemic, we tried to pick them up in our surveys and find out how students dealt with them. Our questionnaire had a health part next to the socio-demographic variables, of course. So our health part mainly focused on mental health using validated questionnaires that are also used in clinical contexts. But please, these are of course survey questionnaires, instruments. This is not a clinical diagnosis, but they're very good instruments. And we also used instruments that are used on resilience and self-efficacy, social capital. We asked about general health, health behaviors, and then we had a part on COVID. So how, COVID symptoms, how did they use tests, were the tests positive, the impact on their studies, impact on everyday life, social life, impact on finances, but also their concerns regard to COVID, concerns about health, concerns about financial issues. And lastly, also here, compliance with the measures or trust in authorities. And as I said, timely topics were, for example, insecurities that arose throughout these pandemic semesters, or also the topic of vaccination. So you remember we did these 9 surveys, and we were, and these surveys were cross-sectionals, but students could repeatedly participate. So we always sent the surveys to every student. So we had a mailing list about 13,000 students, and the participation rate varied between 10 and 20%. But overall, at the end of 3 semesters, we had reached about 70% of the students, meaning that at least 70% at least participated once in the survey. And there was a number of students also that participated 2 or 3 times. So we have cross-sectionals, but also a longitudinal approach, which we kind of see as an open cohort design. Interestingly, and also happily so, each cross-sectional sample was very comparable. So we consider our cross-sectionals to be representative. For one, because they're very similar to the data that we have from the university data. So what university tells us how the distribution about gender distribution or age is, but also because they are so similar. So if you look at these pie charts, for example, which represent the faculties that participated, so the students gave us their faculties, you can see that they're very similar. So across these 9 surveys, we had similarities in the distribution across faculty, but also regarding the distribution of gender and age. So the mean age was always around 26.5 or 27. We have a slightly overparticipation of females, which is rather typical for surveys. Okay, I'll just head into first results from there on. And like to start off with our results on the COVID-related preventive and risky health behaviors. Here I present data from a study that we published, and here I rely on data from our very first survey, in which 2,373 students participated. And we asked them here, do you follow the recommendations on? And that's an instrument that we used and adapted according to the pandemic recommendations and containment measures. For the analysis, we focused on social activities and mobility because those were the items where students had most difficulties with. And we were interested in gender and age differences, among other factors. So just for memory's sake, these are the containment measures that were recommended at our baseline survey in March or early April. And I highlighted the ones that we then did analysis on, which are maintaining distance to other persons, avoiding unnecessary journeys by public transport, avoiding gatherings of more than 5 people, and staying at home. Actually, we also used not leaving the house if possible. This is a table where we show the results. We asked, do you follow these recommendations? And I highlighted here in red the answers where students said, I never or rarely follow this recommendation. And you can see that this percentage is overall rather low. It lies between 1.4 to 4.7, with an exception of not leaving the house, if possible. So that was a recommendation that was really hard for students to follow, as was maintaining distance to persons. So about 5% said that's something I never or rarely do. On the other hand, we see a very high compliance with the containment measures. Now, this is the result of the logistic regression. And as the table is rather intense, I kind of point out here on the side, which are the main results. We wanted to know which factors, socio-demographic, but also other characteristics are associated with non-compliance. And one of the main results was that there's a gender association. So males had a higher risk or higher odds to not comply. Age was a factor. So the older age or the older students complied better. The information source played a role. So people who used public health or health information sources complied better. The concern that people felt with regard to COVID health concerns played a role, and also trust. So we see these are factors that with which we can also use protectively and preventively if we want to increase compliance. Yep, I'll go through there. Now, coming from the compliance, we move to the question, how did next to these impact on their social mobility, for example, that the compliance measures caused, how did COVID impact on their studies and their social life other than that? And again, I show you a complex graph, and I highlighted a few aspects that I would like to point out. Maybe just to help you read the graph better, the color code. So blue and yellow stands for agreeing with the statement that we gave them, and gray is partly, and then orange and light blue is do not agree. So when we look from the top down, we always see the people up to yellow, they agreed or rather agreed to our statement. What we found is, and that we found strongly in the first semester especially, that students reported that their life structure had changed. So their study table had changed, the life structure had changed. Also in the qualitative remarks, they said, well, we don't really know when to get up. And so they really had difficulties with the life structure change. They also agreed with the statement that they were lacking social contacts to fellow students. On the other hand, and that's something positive, is that the majority, more than 80%, agreed that they enjoyed having time with their families. So that's something that we also saw a lot in the general population, that people said they enjoyed the time that they had with near ones. From this table, you see that there are some statements where the blue and the yellow line are very large. So there's a large majority that agrees. But you also see that for other statements, there's a division. So it's really a half-half thing. And two statements where we see this is the question on how did self-study, how did they experience the increase in self-study? For some, this was a huge challenge, and for others, that was easy. And when we saw these differences in the way students reacted to these changes, we realized that there are probably different groups that we have to consider when we do our analysis. So what we did, we ran a latent class analysis to identify these distinct groups and with respect to the impact, so the subjective impact that the students felt due to the pandemic. And in fact, we found three groups. One, which we call the low impact group. So these are students that said, well, I don't feel a lot of impact. So they would tend do not agree with the impact statements. We have a moderate impact group, and we have the high impact group. And when we use the latent class analysis to look at these statements or the impact that we ask them about, we see there's a clear pattern. And so this is really a nice differentiation of our student body. Just look at these examples. For example, the question here in this this one graph is, how are you doing at the moment? And the low impact group shifts, their response shifts to good and very good, while the high impact group, their responses shift to fair, poor, and very poor. So we have these clear distinctions in these groups. And we see that for a lot of questions, also for higher proportion of self-study, for example. You always see, you know, these groups differ in their pattern. And we use these latent classes then in our later analysis, and I'll come back to them. So we looked at protective behavior. Now let's look at risky health behavior. And we were interested in the risk behaviors: smoking, alcohol, and marijuana. Smoking actually didn't provide such a change, but for alcohol and marijuana, we did find very interesting changes. So here we use the baseline data at T0, and we used the first two follow-up surveys in which we asked also on these risk behaviors. And what we found was that 80% of our student body said, I drank alcohol in the 30 days past. So that was a pre-lockdown period. So that's the baseline alcohol consumption. And we asked how many drinks they drank as well. And 77% said an average 1 to 2 beverages on such an occasion. But we also had 31% who reported binge drinking, which is more than 5 beverages at an occasion where you drink. Then we asked them about, then we looked at the change. So at the survey follow-ups, we said, again, we asked the same questions: how much and how often did you drink in the last 30 days? And that allowed us to investigate the increase or the change in alcohol consumption. And while a good half consumed as much as usual, we see that 18% consumed more and 25% consumed less. Similarly, those who smoked marijuana, there we saw that about 27%, so about a third, consumed more during the lockdown, and 11% consumed less. And again, about a half consumed as usual. So we see there are changes in both directions. In this further analysis, we were interested to understand, so who drinks more or who smokes more, and what could a factor be that explains these differences in behaviors during the lockdown and in the consequent surveys. And what we did is we investigated the baseline drinking behavior. So how many drinks did people drink at baseline, pre-lockdown? And we see in this very first graph, and below down here, total number of drinks. And on the vertical side, it's the probability that you drank more during, at the survey, at the follow-up surveys. And we see there's a clear trend. The more you drank at baseline, so the more alcohol you consumed, usually prior to the pandemic, the more you increased your alcohol consumption during the lockdown and during the pandemic. We have two lines here. The first, with the dark one, indicates the association at the first survey, which was in the lockdown still, and the second one was after the lockdown, but still the schools were still closed. And we see, luckily, that the second survey, the increase in consumption already went back down. Okay, so but we see a strong impact of the lockdown on alcohol consumption. And here, the second graph, you see, we use the latent classes to understand if this change in alcohol consumption had also to do with the impact that the students perceived. And we see there is an association between the higher impact that students perceived and their increase in consumption of alcohol. These two graphs actually show the same, but for marijuana. And again, now we look at the days that they used to smoke prior to the lockdown and the increase probability. And again, we see that the more frequently people smoke prior to the lockdown, the more increased behavior they would show during the lockdown. So again, a clear association. On the other hand, the impact, the latent classes here do not show the association that we would have assumed. In fact, we see that the people with a lower impact had a higher risk of smoking more than prior to the lockdown. But I think this nicely shows that not only the impact was relevant, but the fact that the lockdown occurred and your previous alcohol consumption or marijuana consumption was predictive of your lockdown consumption. Yeah, I think I mentioned these points already, so I can move on. I'd like to now talk about anxiety. We investigated anxiety and we published 3 studies, 3 papers on this, and I will report on some of our results. So first one, we really looked at cross-sectional on our very first survey. So this is a cross-sectional sample in the lockdown early on, and we used this general anxiety disorder scale 7, which is a score which allows you to kind of differentiate in minimal, mild, moderate, and severe anxiety symptoms. And what we see here is in the overall sample, we had 16% of students who reported symptoms that would confer with a moderate anxiety level, and 6.4% showed a severe anxiety level. Now, when we looked into our latent classes, we see a very different picture, and it kind of underlines how important it is to understand that there are different groups of students, and that depending on how the pandemic impacted you subjectively, you might have really different reaction to it. Because what we see is that we have a far higher impact, or we have a far higher prevalence of anxiety, severe and moderate anxiety, in those people who felt a strong impact. So latent class 1, which was actually 27.5% of our study, of our sample, they had a low risk. So they had, like, their mean sum score was 3.6, while the latent class 2, that was 45% of the student body, they had a mean point score of 6, and latent class 3, the heavy impact, they had a mean score of 10, which is already the level where we talk about moderate anxiety. And actually, they had an increased risk of so they had a prevalence of 53%. So a really strong level of anxiety in these people who felt the subjective high impact. Okay. Again, here we were interested, of course, in other factors that we can consider, that we have to take into account. So we ran regression models, both linear using the score, but also logistic using cutoffs. And we see, as I already reported, that latent classes, so the subjective impact score, the subjective impact groups were really important. We see latent class 3, the high impact, had an increased, this is a better, let's take this one, increased odds of being moderate to severely anxious of 22. So this is really an enormous increase of risk in these people of experiencing a moderate to severe anxiety. But also gender played a role. Men showed a lower anxiety level than females. Age played a role, but very marginal increase in odds, one must say, even though it is significant. And the faculty played a role. We did from time to time see faculty differences, and that's also why I'll show you that Later, we once also did an analysis looking at health professions and non-health professions, because we assumed that that might be the explanation from time to time. So for anxiety, I think the main message here is really we saw these strong impact on anxiety levels. We had no prior population data on anxiety levels, but we could see that depending on the subjective impact of COVID, we see a far greater impact on anxiety, which kind of shows that this is a COVID impact and a COVID caused by COVID. So the next topic would be depression. And for depression, we again could use various data because we asked this also more than once. And here, this is a study that we published where we used data from April 2020 and from October 2020. So that was the autumn semester. Here we used the patient health questionnaire PHQ, which is an instrument that asks different depressive symptoms or symptoms that are associated with depression. And this is a score. This is not a clinical diagnosis. But one says that if somebody has a score above 9, you can speak of a clinically relevant symptoms. Okay, so depressive symptoms. Yeah, so this is a first picture of what we found. In this analysis, we had the possibility to take data, Swiss data that already existed. And that was really nice because it allowed us to show that we have an increase in depressive symptoms. The Swiss National Health Survey in 2017 asked and used the same instrument, the PHQ. So we constructed a matched sample, matched for age, gender, and sociodemographic variables, and could then compare this matched sample with our student body. And what you see here is the SHS column, that's the Swiss National Health Survey from 2017, and the HES-C, that's our data. And when we now move to the highlights, which are here in blue, we have the moderate depressive symptoms with a score above 9. And we see that in the Swiss survey 2017, there was a prevalence of 8%, while in our student body, we had a prevalence of 20% or 21%. So a threefold increase with regard to moderate depressive symptoms. And we see a similar increase for moderate severe, okay? So this is I think, a very nice, even though not nice result, of course, that we can show that we actually have a COVID impact here. And this for women as well as for men. Now, just using our student body data, we then again looked for factors that are associated with depression during COVID. And again, we find gender, we find age. Here we also find the impact of nationality. Non-Swiss had a higher risk of developing depressive symptoms. Luckily, we see a protective impact from resilience and social support. So these are positive results showing that these are very nice protective factors. And we also see that concerns, again, a high level of health concerns with regard to COVID is associated with increase in depressive symptom score, which you don't see on this slide, but also in the continuation of this logistic regression, we would also see that binge drinking, marijuana, and physical inactivity play a role as well and are associated with an increased risk in depressive symptoms in students. So summing that up again, we see these depressive symptoms, we see the threefold increase with regard to older data, and something I didn't show, but I'll come back to later when I show you longitudinal data, we did not see a change between April and October. So the level of depression in the early pandemic was just as high in the later pandemic. I'll now come to the longitudinal perspective. And for that, and to kind of show you how beautiful our data are, is this slide. I'll have to quickly explain it to you. What you see here is the time period from January 2020 to August 21. So this covers our survey period from April to June. And you see our surveys up here, T1, T0 to T8, and the lines kind of help you orientate yourself. When were the surveys done over this time period? What you also see in this slide is the Stringency Index. I don't know if you know about the Stringency Index. This is an index that calculates how stringent the containment measures in the respective country were at the time. And so if the Stringency Index is 0, like here in January 2020, when we did not have a pandemic in Switzerland yet, there was no containment measure applied at all. And if it were 100, this would be a complete lockdown. Everybody's in their homes and doesn't go out. So we have variation in the stringency of our containment measures. And you see this very nicely across the time, how the stringency changes. There was a loosening of the containment measures here in summer, for example, and then it went back up again. And the other, what you see here is the cases of COVID in blue, and then you have the deaths, so of COVID in red. And this gives you a picture when our surveys were done, and that we actually had surveys at various time points, allowing us to kind of also understand our longitudinal data, and referring our longitudinal data to specific stringent times or less stringent times, which is important when you look at anxiety over time or depression over time, for example. So this just for you to see how our survey was aligned, or was kind of actually covered these different phases. So now let's look at longitudinal data. The GAD-7 is the anxiety, the general anxiety index, and we asked that repeatedly, as you can see in almost all surveys, with exception to T2. And let's look at this blue highlighted part down here, which the two lines represent here, the dotted line, the moderate anxiety level, and the lowest line, the severe anxiety level. And you can see, I remember I showed you the very initial data on anxiety in the baseline, which was already high. It dropped in the first semester, and we were actually quite happy about this when we analyzed the data. But then it went back up again, and it stayed high throughout the last 2 semesters. So we see that anxiety was high in the beginning. There was a relief at the end of the lockdown in March, April, May. And then anxiety in students went up again and continued to be high. This is also a longitudinal measurement where we compare health professionals with non-health professionals. There's a lot of studies that say health professionals had an increased stress because they were exposed to COVID in clinics, etc. And our students partly were exposed, but we see that our health professionals actually could deal with, it seems they could deal better with the pandemic condition. They show, over the whole time, they show a lower anxiety level than the non-health professions. This is depression. And I think my second last slide. And again, you see that there is a change, but an increase of depression over time. So T0 and T3, that's April and October. I had just shown you the results there with these high depression, the 3-fold increase of depression. But you can see in our last semester, it even went higher than that. So there was an increase of depression over the 3 semesters. And similarly to that, we see that loneliness increased. This is an unpublished slide, but it says here that they agree, completely agreed to the statement, I am lonely. And here also you see the last semester, or this is the second semester actually, the autumn semester of 2020, we have a high percentage of people who feel very lonely. I come to the end. I would like to kind of pull this into three thoughts. One is how generalizable are our data? I have to say, of course, we investigated students. The students that we investigated are probably not different to any other student in Switzerland, but they might be different to other people in the same age group who are already in working life, who are doing an apprenticeship. But for the student bodies across Switzerland, I think we could say we're probably very representative. I think it's important to point out that we find different risk groups. We find factors that are associated with increased mental health conditions or with behaviors. And we also see that the student body isn't homogeneous. So we have to differentiate the student body when we address these issues. And the last is, I think, the point of preparedness. We have to learn from what we went through, and we have to realize that we have to be prepared for crises in future. This is going to happen in some way or another. This might happen again. So we really have to be prepared and take these data and learn from them and adapt our university and society to be more resilient. Thank you very much. That's what I wanted to share with you. Can't hear you.
Excellent. Thank you so much. Yep. And we have Hilal unmuted.
Thank you very much for this really insightful presentations. I mean, some of the fact that you highlighted are things we can sense and experience every day in university and interacting with our students. But it has very different impact when you begin to see the numbers. And it's very interesting for me how some things sort of change during the course of the pandemic, where others, like depression, remains constant. Just one question to clarify with respect to your last slide and the generalizability of the data. Are you aware of any other studies that were conducted in Swiss universities addressing mental health during the pandemic?
I'm aware of one other study. It was the ETH in Zurich. They published a paper on a student study. That was a study that they also have longitudinal data, but in a far smaller sample. And they found similar results with regard to anxiety. Their pre-lockdown, they had pre-lockdown data, and then they had at least what they published so far was one lockdown survey, and they also saw an increase in anxiety.
Mm-hmm.
Yeah.
Did you, in your study or any other studies that were carried out in other countries, looked at how the different groups with respect to the stage of education, were affected? For example, the getting into starting in a university for people the first year, it's a completely transformative experience. It's a way to adulthood, it's a way to independence. It's, so for people who had to start during this period, it must have been I would expect that the impact would be much higher. The same can be said for groups who were about to finish and graduate, because their sort of prospect for getting a job and career advancement were dramatically impacted. I was wondering whether you have dissected the data to look at these two different groups or looked at this.
You're absolutely right. I would assume the same, that especially the second semester, where students started in the online mode in their first semester, so they didn't even have a chance of remembering how uni was, pre-pandemic. Actually, we we asked for their semester, we asked if they were bachelor or master, and we used them in some of the regressions, and we didn't find strong effects, but we found age effects. And maybe this was actually then, kind of confounded there. So that we put in both, maybe we couldn't see it. But I just showing you the data today, I thought we have to look at the second semester and just look at the second semester separately once more. Because if you remember, there was this jump in loneliness. And that could be, of course, that right? That could be that that this is the first semester effect. But we tended to have people throughout all semesters. So it's hard for us, probably, it's a question of power also, if we have enough power to identify the impact on, but I'll check it again. I think it's an important point. Yeah, and the other thing, the ones that kind of were at the end of their studies, we didn't look at them separately for health with regard to mental health, but we captured some of their insecurities. So we captured them with the statements, I'm afraid I won't get a job, or I might not be able to finish my studies as planned. So there were insecurities there. And we're currently working on qualitative data on insecurities. So we will, that we actually asked them in our last survey, we asked them, what makes you insecure in view of the pandemic and in view of your future? So we're working on dissecting those data currently.
In your study, in several of your papers, you sort of sought to decipher and identify sort of positive and negative predictors of anxiety, depression, and mental health. Can you expand on the value of identifying these factors and the potential of using the potential use of predictors for prevention of anxiety-related disorders or mental health problems?
Yes, yeah. I mean, there are two sides to it. For one, I think we see that resilience, coping skills, social support are protective factors. Now, you can say this is not new. We know that. I mean, there's evidence that these are protective factors, but we can see that they are protective factors in such a crisis situation and in these young people. So from a preventive point of view, I think we have to think about, as universities, how can we strengthen resilience? How can we strengthen social support in our universities, among students and lecturers? I think that's something to think about, because it goes beyond, just being pandemic resilient. It goes into being resilient for any crisis, be it a professional one or a personal one later in life. So I think that's worthwhile, kind of showing this under these circumstances. And the other is that we see that there are certain groups that might need some more focus. The gender effects that we found are in line with what literature shows. So we didn't find a surprise there. We see expected gender differences, but maybe when we do campaigns, that will help us to address people more directly, right? And the other thing is, what I really thought was a striking result was this, that the baseline consumption of alcohol, for example, is a predictor for how you react in crisis, how you react in under stress. And that's also something that we should try to address, be it with campaigns, be it with offers. We have students who might already have an alcohol problem. So yeah.
Yeah, the same with eating disorders and other problems. Yes. I think, when it comes to resilience, I wanted to ask sort of, what do you think are some of the things that universities and maybe, faculty and people who interact with the students could do to help in terms of training students and, sort of enhancing their coping and resilience skills, and whether this is something that perhaps we shouldn't wait until students get to university to teach them. Should be something, that is, taught both also at home, you know, and then over the years.
Yeah. Well, I mean, resilient is the competency or the fact that you can deal with difficult situations better, that you have a better outcome than a less resilient person, right? So to think about and what helps there. So I think social contacts always help. Good relationships with people that you can that are a resource to you when something goes wrong. So I think developing social skills, communicative skills, emotional skills is always a strength. Always strengthens resilience. A big topic is mindfulness in these past years, which is something that we actually tried at the ZW to improve or to address during the pandemic. So there were like online courses on mindfulness. I don't know how well they were attended, since people normally don't have the time for these things, right? So the question is, do we give these aspects enough priority in our, in our private lives, in our professional lives, in when we raise our children in school? So maybe that's a thought to follow up on.
So you in the presentation, again, some of your work, you addressed this issue of sort of compliance by young people, and particular university students, to the rules imposed and the lockdown and the preventive measures. And the numbers were very interesting in the sense that, you know, there's large percentage of the, you know, we're not in compliance. So you recommended that, you know, there is a need of targeted sort of communication approach to the youth. Do you feel that this was not sufficiently done during the pandemic? And if it was, you know, what do you think is the best way to do this?
Well, maybe firstly, I was actually impressed, but then you hear, you know, how well they, how compliant they were. Of course, we have to consider there might be a little bit of social desirability in answering these questions, right? They know what's expected from them. But nevertheless, I think this was actually quite considerable. On the other hand, in another study that we've been doing called COVID-19, where we investigated how young people perceive the media attention that their age group got throughout COVID, we realized that they didn't feel addressed, really. I mean, very early on, young people were told, well, you're not concerned, but you have to behave, right? That was the message. And that's the wrong message. If there's a crisis, such as a pandemic, everybody's concerned. And everybody's concerned in their own right, and they might have different concerns. And so I think that was an initial flaw in the campaign, telling certain people you're not concerned, but you have to behave. And that's not a good message.
Yeah, I was actually pleasantly surprised in the fact that even within, I believe in correct me if I'm wrong, that the percentage of students who were concerned were about 50% in terms of about their health, and the others just, you know, felt that, you know, they probably get infected and get over it. But the great majority of the students had quite a lot of concerns about their family, their grandparents, and their, you know, something that, you know, sort of they thought about quite a lot during the lockdown period. And I think one thing in terms of messaging that sort of have been overlooked is the fact that we're dealing with this beast that we still don't understand the long-term consequences. I mean, the idea that young people can get sick and get better quickly and go back to normal life is not necessarily true. So from the long-term health perspective, you know, we don't know what, you know, whether people are infected will potentially be more predisposed to other diseases. So the message should have been, it's better not to get infected at all, and for all age groups. So you also, just before we move to the next part, highlighted that in terms of targeted approaches, that non-Swiss nationalities, international students, were a particular group And that sort of makes sense from the point that, they're isolated, they're away from their family. And many of them, for example, like students from China who could not go back because they would have to quarantine for several weeks, and they were, out of touch for more than a year with their family. But you highlight that it's important to continue to monitor and do more research on these groups. Could you elaborate on this?
You mean specifically on the
international students?
Yeah. I mean, we saw the effect only in depression. We didn't see it in anxiety, which kind of shows that it's not that they're more anxious, but it's really about probably the loneliness and the isolation that occurs when you're in a foreign country and you don't have the social network that you can resort to locally. I just wonder, just thinking about what can university do, I think yes, I think sometimes you have to address groups differently and just say, hey, we know you're in a more difficult, time than others right now, or you have more difficulties, try to help them network amongst them, try to, I don't know, we have a PhD student who came during the lockdown and left during, a crisis, a really difficult time. So that was really hard for some people to then connect socially. And I think we can help providing structures. Would probably be helpful also outside of a pandemic to provide newcomers structures to integrate socially.
So I know we've discussed this topic on several occasions, together, and the idea that addressing mental health in academia requires more of a holistic approach, that addresses not only the mental health of the students, but also, the entire community, i.e. the faculty, the staff, and this. I was wondering whether, have you looked at this in terms of the role of the professors, the teachers, or what are your views on this topic?
Well, we didn't investigate the lecturers or the staff at university. We addressed a little bit the relationship that students had with lecturers in like we introduced a statement, my lecturer has time for me, or I can contact him or her when I have difficulties, and kind of seeing that actually, that didn't shift anywhere drastically. So that, I think that was still okay. In our qualitative analysis, or let's say in our qualitative parts, because students could always give us messages and write down what they were concerned about, and of course that's not representative, right? But some students were a bit unhappy about the strictness in some of the ways that university dealt with exams, or I would hear people say, well, they expect extreme high flexibility from us students, but they're not so flexible vis-a-vis, to our needs. And so I think it's worth to maybe discuss this experience, among lecturers, among responsibles with students. How did they experience it? How could we, what could we have done to improve their situation? Yeah.
Galina, you want to?
Yes, well, thank you so much for such an interesting presentation. It was so really great. So I was wondering what do you think the mental health issues are not being addressed very well in academia at the moment? And what are the approaches for us to actually turn this around?
Oof. I mean, academia can be quite stressful, and studying can be quite stressful. I don't know if you can take stress out of life, and if that is the aim. But we can, we can teach to deal with it better, or to identify your personal priorities better, to understand where are you prepared to sacrifice time and energy? Yeah. It's I think it's difficult to really pinpoint. I wouldn't say there's one issue that we have to, address. It's more like a general thing. I mean, we see that mental health issues are increasing worldwide. It's not only an academia problem, right? But we see that, and so it's something to address as a society.
Yes, and I probably actually was quite surprised when I looked through your study on depressive symptoms in Swiss university students that more than a quarter of the students actually reported depressive symptoms, which is very much higher than the general population. So why do you think the academic community is so disproportionately affected compared to general population? So you already mentioned stress, for example, but do you think maybe the system itself perhaps needs a bit of a shift from individual to more of a systemic approaches to tackle these issues?
Mm-hmm. Well, maybe first a correction. Our data are purely pandemic data. Okay, so the prevalence that we found probably was not as high if we had asked the same questions, some months prior to that. And that's why we introduced these national survey data, the Swiss data from 2017, kind of show that we see an increase during the pandemic. Now, if we go back to the 2017 data, which was also, a matched sample, so highly educated, a representative sample in that age group, there was a 8% prevalence of moderate to severe depression. Also not nothing, right? That's almost 10%. 1 in 10 who shows depressive symptoms that are clinically relevant. So yes, if as we see populations show an increase in mental health problems, and the latter data indicate that 20% of the population have a mental health problem at some time point between 0 and 25, that's quite considerable. So yes, I think it does need a systemic approach.
Mm-hmm.
Also, with regards to your studies, so do you think we should have more integrated approach of surveys on a national level, for example, to really get a good picture of what is going on?
Absolutely. Yes, I think, there are some studies on mental health, of course. And we have studies in like the national survey, which ask about mental health. The data situation actually is the poorest in children and adolescents. Starting your third decade, data get better, but it's worthwhile having good data if you try to change something on a system base, because we also want to see that there's an impact. So we actually need monitoring. We need to see how things develop, to also evaluate the interventions that we would then happen and are done. Mm-hmm.
So maybe to close with a few comments and questions. So given that you've been sort of sharing this data both in publication and publicly and in meetings, has this changed anything? Do you see that that universities are taking this more seriously, or has this changed the university's approach? The pandemic has only helped highlight the challenge that already existed. What I'm trying to see is, have you seen a change, a meaningful change in how universities try to address this problem?
Not yet, really. I think people who are in charge for mental health services of students or in charge of health promotion, they've seen the data. They realized that there was a problem or that there might still be a problem. But I think currently the feeling is, okay, that was COVID. And once COVID is gone, everything's going to be fine again. So I think it's up to us to kind of also look into what's happening after, what do we see in the after COVID phase, whenever that starts.
But the studies from the UK, the US, and many places around the world, even before COVID, right, have highlighted, that this is a serious problem in academia. And, that's only focusing on the students population within universities.
I think so far, at least from the experience that I can speak of, it's a very, it really depends on the institute, on the department. It's not a concerted action that's being taken across universities. So it's maybe still a very individual engagement if a head of department says they're going to change something. But of course, let's also see it. We have, almost all, I'm sure every university in Switzerland has some kind of offer to students that have difficulties, that need help, that need support. So it's not that we have nothing, and these tend to be for free. And if students need longer treatment or longer therapies, they get the help to find such a therapy. So I think our services are good. Maybe we have to enlarge them. Maybe we have to increase the capacity that we have. Probably we have to inform students better that it's fine to use them. There might still be, the risk of stigma. Yeah,
I agree. I completely agree with you. I think, most universities have some form of counseling, guidance, and assistance. Usually not enough based on student testimonies, but a lot of students are also, do not make good use of these services because the stigma. So I think, fighting the stigma associated with mental health and probably having more of a community-based approach where it's not viewed as only a student problem, because it's definitely not. And people realize that, everyone in university experience mental health challenges on a daily basis, different times and to different levels. But I like the idea of, understanding what are the very specific factors that trigger this in different population, because I think that's where we need a bit of more studies, understanding the relationship between the different stakeholders, the students, the faculty, the staff. When you look at survey studies on graduate students, you find that graduate students' professor interactions are key determinants of satisfaction and mental health. And so I think there is probably, you need quite a bit of more research into this to be able to develop effective strategies and to educate people how to recognize, when they cross a certain threshold and or part of that mental health, challenges spectrum, and when they need to get help and be comfortable to ask for assistance and support. Well, I think from my side, I thank you again for, first of all, championing this topic and doing this outstanding work to try to provide us with the right facts and numbers to help in sort of the development of effective strategies and policies to tackle this. We wish you the best in your work and look forward to following more work coming from your group. And thank you again for being with us today. It has been a pleasure to have you with us.
Thank you. The pleasure was all mine. It was great. Thank you very much.
Thank you. We look forward to continue working
with
you.
Thanks for joining us today. And thank you to all of our viewers and listeners. And we hope to see you next time.